Welcome back to the Ninja Nerd Podcast. Today we're going to be talking about potassium disorders. It's going to be an awesome episode with hypokalemia and hyperkalemia.
Yeah, I like it. Let's do it. Usually potassium disorders, it's all about, just eating too many bananas, right? Like it can't be that complicated.
Or if it's low, eat a banana.
Yeah, exactly. Done. Podcast over.
Yeah. Now, unfortunately, not that simple, right?
Yeah, it's never that simple.
All right. Well, we're going to be talking about two different cases here, one on hypo and one on hyperkalemia. Let's start off with hypokalemia, go through a patient case study, and then try and figure it out, dissect it, and hopefully learn a lot.
I like it. Let's do it.
All right. So we have a 52-year-old female presents to the ED with complaints of muscle weakness and recurrent cramps. The patient reports experiencing progressive muscle weakness, cramps, and occasional palpitations over the past few weeks. She mentions that the symptoms have progressively worsened, prompting her to seek medical attention. She also notes recent episodes of nausea, diarrhea, which she attributes to stress and just some poor dieting.
Have you noticed like every patient we have has diarrhea? Like,
yeah. Is that a theme so far?
I don't know, but I notice that pretty frequently in most
That's
of our disorders.
That's a good point. I don't know. We have it must be a recurrent
They're drinking
theme.
river water and just spewing out the one end, man. It's all the time. All right, sorry, you go ahead.
No, hey, we'll see if the diarrhea keeps happening.
Yeah, I know.
The patient admits to consuming a large amount of coffee daily and using over-the-counter proton pump inhibitors for her chronic heartburn. Sounds like me.
Yeah.
Just pumping coffee all day long.
Yeah, exactly. And mixing it with omeprazole nonstop.
Yeah. Yep. Her past medical history is GERD. No surprise there.
Yeah.
And no known history of cardiac or renal disease.
Okay.
Medications, over-the-counter omeprazole, and occasional NSAIDs for headache. Review of systems. GI, nausea, diarrhea, heartburn, MSK, muscle weakness and cramps, cardio, palpitations, and then her neuro, no headaches, dizziness, or syncope. All right, let's get into some vitals. Blood pressure is 135/85. Heart is 98. Respiratory rate is 16. Her temp is 37 Celsius, and her SpO2 is 98% on room air. Physical exam, general, middle-aged woman appearing distressed. Cardio, regular rhythm, no murmurs, gallops, but there were palpitations noted during the exam. MSK, muscle tone reduced, looks like this guy over here. And she does have some diffuse muscle tenderness. Neuro exam, she has a positive Trousseau sign indicating latent tetany.
Okay.
That's an interesting one.
That is an interesting one.
All right.
Something going on there.
Her skin, normal turgor and hydration. So she is not dehydrated.
Okay.
Lab testing. Potassium is 2.9, low. Magnesium, 1.0. Calcium is 9.2. Sodium, 140. BUN, 18. Creatinine is 0.9. Her CBC is within normal limits. TSH, thyroid stimulating hormones, normal. And her ABG came back normal. Imaging, ECG shows prolonged QT interval and U waves suggestive of hypokalemia. All right, so we have everything we need, Zach. I think now let's dissect the case and figure out how do we approach this patient with hypokalemia.
Yeah, so when you look at her labs, right, so you get back, a lot of the symptoms are kind of like very kind of vague, right? But the biggest thing is that she's got nausea, diarrhea, picking that up. She's got palpitations, and she's got some cramps and muscle weakness. And so that seems to be the biggest kind of presentation. When I look at her potassium and I see that that's low, that's definitely a trigger. It's a very common trigger for patients developing things like muscle cramps, as well as potentially things like tetany and ECG changes. When I look at the patient's potassium and I see that it's low, I then want to ask myself the question, where is that loss of potassium from the body coming from? Is it coming from the GI or is it coming from the kidneys? And so the best way that you could do that is you could try to look at the patient's urine potassium and kind of get an analysis of that. But again, I don't have that here. And so I think it's just wise to look at the patient's history and say, what does it suggest that this patient is losing potassium from? And when I look at the patient's history, what I notice is that she's having episodes of nausea and diarrhea. So she's having diarrhea. She's probably losing potassium through some way, shape, or form through her GI tract. But there's also one other thing that's really interesting here, and that's why the urine potassium probably wouldn't be super helpful. But I noticed that the magnesium is really low. So the serum magnesium is 1 milligram per DL. So that's definitely low. Ideally, we like to keep that up above 2. So one thing I'm definitely being able to notice here is the urine potassium. It probably wouldn't give me a lot of information, but what I'm looking at for this patient is I'm saying I see diarrhea as potential extra renal loss or a GI loss. And then on top of that, I also see magnesium being low as a potential renal loss. The way that generally we like to look at this is if you can get a urine potassium. If the urine potassium is high, it's a renal source of where you're losing potassium. Generally, if it's greater than 20. If it's low, it means it's not really coming from the kidneys. It's coming from the GI tract. Problem is, in this scenario, she's losing potassium likely from both sources. So it'll probably be some kind of gray zone that wouldn't be super helpful for me. So what I would do is I would say, okay, let's pretend for a second that she has a high urine potassium. If it was, then I would say, okay, what's her blood pressure? The reason why is if patients have super high blood pressure, they're very, very hypertensive, I want to think about potentially like a hyperaldosterone state. Because in high aldosterone levels, your actual aldosterone is going to start causing you to secrete potassium into the urine and reabsorb sodium. And that reabsorption of sodium comes with water and then increased blood volume, increased blood pressure. Her blood pressure here appears to be within an appropriately normal range. It's maybe like pre-hypertensive, but she's not super hypertensive and on multiple antihypertensive medications. So I wouldn't say that she has high blood pressure. So then what I would do is, if the blood pressure is normal, or even if it's like a teensy bit low, that's when I check a magnesium level. And if the magnesium level is really, really low, I think it's probably hypomagnesemia. And the whole purpose of that is magnesium is supposed to prevent your kidneys from dumping potassium into the urine. If you don't have enough magnesium, you're going to dump potassium into the urine. Other things that I could do is I can get an ABG to look to see if there's an acidosis or an alkalosis. And they did give me an ABG and it was normal.
Yep.
So I don't think that she's losing protons in the urine from diuretics. And I don't think that she has like a weird renal tubular acidosis, type 1 or type 2, to suggest an acidotic condition. So from that, I see that she has a low magnesium, she has normal blood pressure, and I suspect her urine potassium won't be super helpful. But I can definitely say that she has low magnesium. I could say, okay, what about the GI? She has diarrhea. If you do have really bad diarrhea, technically you'll lose a lot of bicarbonate in the actual stool. And so they would develop an acidosis. But again, the ABG is normal here. So not everything is going to be perfect and follow a very specific rhythm, an algorithm, I should say. But in this patient, I would say the likely cause is hypomagnesemia as well as diarrhea causing this patient's hypokalemia.
Well, let's give a little pop quiz here to the audience then. So we have a couple things that could be pretty bad, especially causing complications here. If we see here her ECG is showing a prolonged QT interval, and we know we have a low magnesium, what would the patient be most at risk for as far as an ECG finding?
Yeah, that's a really good question. I like that.
And it's a big complication. Do you guys know it?
Yeah, please chuck it down in the comment section. But I'll give you guys the answer. And I think the biggest thing to remember here is torsades de points. And I think Rob set that up perfectly, is that's what you want to watch for these patients, is because patients who have hypokalemia, they likely have some change in the excitability of their muscles, skeletal, cardiac, smooth, and their neurons. And so as a patient becomes hypokalemic, the excitability of their muscles, like skeletal muscles and their nerves, starts actually kind of diminishing a little bit. And so that's why they develop weakness and cramps, all right? The other thing here is that the cardiac tissue is what's weird. It's paradoxical. It actually amps up. And so oftentimes these patients develop like weird tachyarrhythmias. But the biggest thing that Rob said is if a patient has hypokalemia and hypomagnesemia combined, that is a recipe for torsades de points, where the QT interval gets longer, the R wave falls on a T wave, boom, you get torsades de points. And that can break down to VFib, and a patient could easily undergo cardiac arrest. And
then being on that point now, we'll get into the treatment a little bit more, but pretty simple. If they're hypomagnesemia, you're noticing that the QT interval is getting longer.
Yeah.
Just give them magnesium, right?
Yeah, exactly. And that's oftentimes the best treatment for a patient who has underlying hypokalemia and you're starting to develop a noticeable increase in the QT interval. Give them 2 grams of magnesium IV. And what that generally will do is hopefully help to prevent the patient from going into torsades de points. But generally, if they go into torsades, then you have to give them 4 grams of magnesium sulfate generally. But giving a little bit of magnesium is going to be the answer to hopefully help to reduce that QT interval and preventing them from going into torsades or prevent recurrent episodes of torsades de points.
Okay. So overall then, how would we treat not just the hypomagnesemia, how do we treat this as a whole and maybe the magnesium isn't low. What would you do in that case when it's not?
Yeah, so that's a great question. So for me, the biggest thing I look for in a patient who has hypokalemia is I like to look at two things. One is the severity of it. So is it less than 3 or is it greater than 3? So generally the definition of hypokalemia is less than 3.5. When it gets between 3 and 3.5, that's a little bit more mild, and the chances of having ECG changes are a little bit lower. If it's less than 3, they're more likely to have ECG changes. So the first thing I like to remember is, what's the potassium? Is it less than 3? But more importantly, is there ECG changes?
And this patient, 2.9, she's definitely in that state where there could be ECG changes.
Exactly.
Which there were.
Yeah, and so that's what I'm looking for. She has both of those factors there where she's less than 3 and she has ECG changes. And you have to remember what that looks like. So first thing is that usually the T waves will start to kind of flatten or invert. Sometimes what can also happen is the ST segments start to depress a little bit, or you can develop U waves. But the biggest concern, as you said, for this patient is that if the U waves then start progressing to a prolonged QT, they can get torsades. So for me, this patient has both. I wouldn't go the route of giving oral potassium. I would give them IV potassium. And so that's the first thing I would do. Now, depending upon how fast I want to correct their potassium, depends upon the severity. Generally, when it's less than 3, I like to give IV potassium. The big thing that you have to remember is if you're giving it peripherally, if you give it too fast, it can cause phlebitis and it can increase the risk of arrhythmias. It burns like a son of a gun. And so we like to push the potassium a little bit slower, and we like to put it at a rate of about 10 milliequivalents per liter per hour if you're giving it through a peripheral IV. If you put it in a central line, like for example, you run it through an IJ or subclavian or femoral, you can run it a little bit faster because those are bigger vessels, less risk of that kind of phlebitis kind of problem. And so you can run it about 20 milliequivalents per liter per hour. But for this patient, I'd probably give her some IV potassium to get her up above 3. And generally the rule of thumb here is for every 10 milliequivalents of potassium that you give the patient, you should theoretically bump the potassium up in the bloodstream by 0.1. So if I want to get her to at least from 2.9 to 3.5, I'd have to give her 0.1 plus 0.5. So I'd have to give her at least 60 milliequivalents of potassium to try to get that potassium up to 3.5 or greater. And so that's the ideal kind of goal here. If she was greater than 3, or she had no ECG changes, then I wouldn't go IV. I would just give oral potassium. It's not something that I have to rush because if ECG changes can persist, they can increase the risk of torsades. If I don't have any of those and it's not as severe, then I can go ahead and give oral potassium like potassium chloride, potassium bicarbonate, and then allow for that potassium to kind of get absorbed across the gut. So that's what I would do. To stick to your point though, which is really important, sometimes you may not get a magnesium level from a patient. Like you gave me the magnesium, which was perfect. But what I find that happens a lot in the hospital is that you'll give patients potassium. Let's say I have a patient who has 2.9 potassium. I give them 40 milliequivalents of IV potassium. On top of that, let's say that I also give them 40 milliequivalents of oral potassium at the same time. What you'll do is you'll check their potassium maybe 6 hours, 12 hours later, and the potassium will still be low. And you're like, what the heck? I just gave them a boatload of potassium. How is that potassium not rising? That's when you start being considerate of hypomagnesemia.
Okay.
That's when I would check that and then see, is it low? And if it is, give them magnesium because you're going to prevent them from dumping that potassium into the urine. The other thing I would do is I would check to see if they're doing that, do they have hyperaldosteronism? So is their blood pressure really high? Do they have hypernatremia? If that's the case, check them that renin and aldosterone level. And that's where I would consider like an aldosterone antagonist. Like usually we can give things like spironolactone or eplerenone, which are drugs that could work in that potential situation as well. But that's kind of how I would approach treating hypokalemia is what's the potassium level? And then is there ECG changes? And then I would diverge into that on IV or oral. And then looking at after I've treated them, are they getting any better? No. Is there a magnesium problem? Is there an aldosterone problem?
All right. Well, let's move on to case 2, hyperkalemia. Next case, we have a 65-year-old male presents to the clinic with fatigue and unusual muscle weakness. The patient reports that over the last few weeks, he has been feeling progressively more fatigued and has noticed some muscle weakness, particularly when he's climbing the stairs. He also mentions feeling tingling sensations in his hands and feet. He was diagnosed with hypertension and heart failure 6 months ago and started an ACE inhibitor. Right off the bat, Zach, what are you thinking? What jumps out at you there?
The ACE inhibitor. That sounds a little interesting because usually that's a pretty common trigger of a patient developing hyperkalemia. So that right there is making me think a little bit about it. But I guess we'll see if there's anything else that kind of pops out.
All right, so we'll keep ACE inhibitor in our mind then.
Yeah.
Past medical history is hypertension, heart failure, and type 2 diabetic. He is controlled with metformin. Lisinopril, 20 milligrams daily, and metformin, 1,000 milligrams twice daily. For his cardio review of systems, occasional palpitations, neuro, tingling in his extremities, muscle weakness, endocrine, stable blood glucose levels. Vitals, blood pressure is 135/85, heart rate is 78, respiratory rate is 16, his temp is normal, 37 Celsius, and his SpO2 is 97% on room air. For his physical exam, general, elderly male, alert, oriented, and in no acute distress. Cardio, regular rate and rhythm, there's no murmurs. Neuro, mild diffuse weakness, no focal deficits. For lab testing, potassium is 6.2.
Ooh, you know he did.
Oh my God, I hope not. Sodium is 140, creatinine is 1.8, BUN is 29, GFR is 45, ABG comes back. We have a pH of 7.38, PCO2 of 42, and a bicarb of 24. Renin level, high. Aldosterone level, low. We do get an ECG. We have a couple ECG findings here. We have tall, peaked T waves, a wide QRS, and a prolonged PR interval. Based upon that ECG, Zach, what are you kind of interpreting with that?
I'm nervous. This guy's got a lot going on, but the potassium's greater than 6. And on top of that, they also have some peak T waves, a wide QRS, and a prolonged PR interval. That's kind of terrifying. That tells me that this patient's at a super high risk for some cardiac complications, some really bad arrhythmias.
Okay. Well, let's get right into it then. How do you approach this case with all that's going on?
Yeah. So the first thing I would do is I like to do this just because if there's anything concerning, like let's say, for example, patients get morning labs. You get some labs and you find that a potassium is just like really weirdly high. So sometimes we get this a lot in the ICU. You get a BMP in the morning, and you get the potassium and it comes back at like 7.2, and they have no underlying like kidney disease. They're not on any medications. It doesn't make any sense why that would be the case. Always recheck it. That's the first thing that you should always do. The reason why is sometimes you can get, patients get a hemolyzed blood sample. Their tourniquet's on too tight. Sometimes weird things like thrombocytosis and leukocytosis. Those things can also cause like an abnormally like falsely elevated potassium to occur inside of the blood tube after it's been drawn out of the body. And so it's really important to just recheck it. If you recheck it and the potassium's normal, it's probably not real. It's probably just pseudo hyperkalemia. That's the first thing I always suggest, is to recheck it and just pray that it's actually normal. It's because if it's high, then you have to start figuring out why in the heck it's high. Oftentimes the potassium's high, it's usually a renal disease. There's something going on with the kidneys. So that's where I would like really take a look at the patient's underlying renal function and see, hey, is there any significantly reduced GFR? This patient does have a reduced GFR. It's not like in the toilet bad, but it is kind of elevated. And so that does make me kind of concerned. Does this patient have underlying chronic kidney disease? I don't think it's acute kidney injury, because I would expect that if I got like a baseline, I don't think that I would suspect this is probably around the patient's baseline, but I can't know that with 100% certainty. But I do think that there's some degree of underlying kidney disease here present. And I would even bet that that is the case, because I look at the patient's history and they have diabetes and hypertension, the two most common causes of chronic kidney disease. So I'm going to say that the patient probably likely has some underlying kidney disease. I'm going to say CKD, probably somewhere in the realm of like CKD3. So with that being said, I could say, oh, that's the likely cause, but that's not likely the only cause. I think there's some other things going on here. And here's one big thing. Oftentimes, if a patient has chronic kidney disease, you have to be very careful of the medications that you put them on, because they're at super high risk of retaining that potassium. So that's where I would take a look here, and I would say, okay, what are some other reasons why this patient could have an elevated potassium? And the first thing I would like to do is I'd like to see if there's any kind of issue where there's hypoaldosteronism, something that's causing the kidneys not to produce renin, or something that's causing the adrenal cortex not to produce aldosterone, or something that's causing the blockage of aldosterone at the kidney tubules. The whole concept behind this is that in all of these scenarios, aldosterone levels would be theoretically low. And if they're low, then they're not going to tell the kidneys to dump the potassium into the urine and it'll build up in the bloodstream. That's what I'm thinking about. And the way that I like to kind of mark that out in my head is, one is that something is telling the kidneys not to produce renin. Oftentimes diabetes and NSAIDs are usually a very common trigger here. This patient does have diabetes, but one thing that's funny is I got the renin level. You gave me a renin level, it was high. Theoretically, it would be low if it was diabetes and NSAIDs. The next thing I would do is I would go and I would say, okay, could it be that the adrenal gland is like not functioning and it's not pumping out cortisol and it's not pumping out aldosterone? That's possible, but none of the history suggests that. What I do see is ACE inhibitors and ARBs and ARNIs, which we use in patients with heart failure and hypertension. That's a very common offender here because they block angiotensin II from triggering the production of aldosterone. And what is this patient on? An ACE inhibitor. So I think that the ACE inhibitor is probably suppressing aldosterone production to a degree. With that being said, the last thing I would look at is there any potassium sparing diuretics or Bactrim, which is a drug that we use in patients with UTIs that can block aldosterone at the kidney tubules. And I don't see that. So the only two offenders that I'm really seeing here is that he has underlying CKD, probably CKD3. So there's already a reduced GFR that diminishes potassium filtration. And on top of that, there's probably a hypoaldosterone state from ACE inhibitors that's suppressing aldosterone production and not being able to secrete or excrete potassium into the urine. I think those two combos right there is the primary offending agent. And so that's what I'm seeing here, and that's what I would kind of go with. Now, I think going back to the other thing is that there's always the possibility, and we didn't talk about this as much with hypokalemia, but there's also shifting. So sometimes potassium can move in and out of cells. So for like an example, in patients who have hypokalemia, if they're having too much insulin or if there's an alkalotic state or beta agonists, like we use albuterol, that can shift potassium into the cells and drop it down in the blood. The opposite would exist for hyperkalemia. If the patient's not making enough insulin, if they're also getting drugs, particularly like beta blockers or digoxin, those kinds of things, or acidosis, that can also shift the potassium out of the cell into the blood and rise the potassium. So I would have to look in the history. Do I see any beta blockers? No. Do I see anything where the patient has an acidosis? You gave me an ABG. I don't see any acidosis there as well. The other thing that you want to think about is lysis of cells. So hemolysis, tumor lysis syndrome, and rhabdo. Tumor lysis syndrome, I'd be looking for underlying history of like a hematological malignancy. I don't see that here. Rhabdo, I would be seeing history of seizures or crush injuries that would cause destruction of the muscle cells. I don't see that here. And then I also would expect some kind of anemia. I didn't get a CBC, but I would expect there to be some type of like fatigue, jaundice, something weird there. And I don't suspect that to be anywhere in the history. So it's also important to just make sure to think about these diseases as though, yes, in hypokalemia, it's probably that you're dumping potassium out in the urine or you're pooping it and vomiting it out. In hyperkalemia, your either kidneys are just kind of like holding on to the potassium and retaining it because you're not filtering it or excreting it. But don't also forget the possibility of shifting of potassium. Am I shifting the potassium in the cells in hypokalemia, or am I shifting it out of the cells in hyperkalemia? And so that's something else I would kind of go through in my thought process to analyze the patient's underlying history. But I think here we got to the bottom of it. It's likely CKD and a combination of ACE inhibitor use.
So let's talk about the complications. Now, a lot of bad things can happen with hyperkalemia.
Yeah.
Let's try and quiz the audience again here. So we had some ECG changes, right?
Yeah, exactly.
We had peak T waves, we had prolonged PR interval, flat P waves, and a wide QRS. What would that most likely manifest in a patient?
Yeah, that's a good one. So definitely think about that. And you guys, I think that's really important because one of the things that can happen, and I've seen this, is that after that kind of wide QRS, it starts to get this weird kind of like sine wave pattern. And that's what kind of gets concerning, because when you see that sine wave pattern, that's starting to indicate that the patient's getting ready to go into cardiac arrest. Likely it can break down into VFib or it can progress to asystole, but that's the big thing I'd be super, super concerned about. The other thing that you made a good point of is when you see that a patient's PR interval is kind of getting longer and their P waves dropping and their QRS is getting wider, it also could indicate that the patient's developing heart blocks. Yeah. And so I would be watching out for AV blocks in these patients as well. So heart block is definitely a really big offender. And then again, as you pointed out, the progression of ECG changes, peak T waves, prolongation of PR interval, flat P waves, widening of the QRS. But the concerning sign is that sine wave that can go VFib or asystole.
Yeah.
So cardiac arrest is the huge thing. And sometimes, believe it or not, it may not follow this progression. Sometimes a patient can go directly into cardiac arrest if the potassium's high enough. And so that's definitely really, really something to think about in these patients.
All right. So then we have the complications talked about.
Yep.
What do we do now with treating this patient?
Well, the potassium is greater than 6 for this patient. It was 6.2, I believe, right?
Yes.
Yeah, 6.2. And on top of that, she has EKG changes. I mean, he has EKG changes. So for this patient with the greater than 6 and peak T waves, prolonged PR interval, wide QRS, I'd be crapping my Huggies a little bit right now because I'd be getting a little nervous. So right away, first thing, if you notice any elevated potassium and EKG changes, slam some calcium into the patient. So calcium gluconate, oftentimes the best thing. The reason why I like calcium gluconate is because you can give this peripheral. And comparison to calcium chloride, you have to give that via central line because it's a little bit caustic and it can cause phlebitis. So right away, 2 grams calcium gluconate usually is good enough to get started. And what you're looking for is when you give the calcium, the moment it hits the bloodstream and it hits the cardiac membranes, it should stabilize it. You should see, for example, the peak T wave starting to drop. You should see the QRS is starting to get a little bit narrow. You should see the PR interval starting to get less long. And you should notice that pretty quickly. And so that's one thing I would do. And if they have bradycardia, again, give them calcium gluconate because you're going to see that the actual bradycardia will kind of start improving and you'll see the heart rate kind of pick up. You'll notice the changes in the AV blocks. You'll have less of a prolongation of the PR interval. So that's right away the first thing I would do. Second thing, we talked about this a little bit, and hypokalemia is that one of the reasons why patients can develop hypokalemia is you're shifting potassium into the cell, right? I want to get potassium out of the bloodstream into cells because I don't want that to touch the cardiac membrane. So what I got to do right away is I'm going to give things that are going to shift the potassium into the cell. Insulin. Usually you give them a pretty good dose, 10 units. You're going to give them like regular insulin. And when that hits the bloodstream, it's going to hit those receptors and shunt the potassium into the cells. The question that you sometimes get on the exam is, do you give glucose with it, like dextrose? For example, Rob, if I had a patient who's hypoglycemic and I gave them insulin, should I give them dextrose? Probably, right? Because if I give them insulin and they're hypoglycemic, I'm going to shunt all the glucose into the cells and drop their sugar down more. That's when you would give it. Is when a patient's kind of hypoglycemic or euglycemic, give them dextrose. If they're already hyperglycemic, just give them the insulin, keep an eye on their sugar, and if it starts to get low, give them an amp of D50. But that's generally the way that I would do this. So insulin to shunt the potassium into the cells. Also albuterol. Now this isn't just, hey, Granny, take a little puff of this inhaler. No. You're giving them a heavy dose of nebulized albuterol, generally like 20 milligrams. And so you're running these kind of large doses into the bloodstream because albuterol is a beta-2 agonist and it's going to stimulate the sodium-potassium pumps and shunt the potassium into the cells. Last thing, and I hate when people do this, is you only give bicarbonate if the patient is acidotic. If the pH is not less than 7.2, or some even literature will say 7.15, don't bother giving bicarbonate. Just don't. So only give bicarbonate if the patient's acidotic because it'll help to reduce that shifting.
Which he wasn't.
Exactly.
No
so we don't need to give any bicarbonate. So I'll give 2 amps of calcium gluconate, give 10 units of insulin. This patient does, I think the sugar was controlled. So I'd probably give some D50, give 20 milligrams of inhaled albuterol, bypass the bicarbonate. And then I would keep a close eye and I would probably check the potassium in a couple hours and see if it's gone down. The whole point of these things is to get the potassium out of the bloodstream as quick as possible. Problem is that this only lasts for a little bit. So once you shift the potassium in, over time, potassium will just go back out into the bloodstream. I have to get rid of total body potassium. That's where I'm either going to use their kidneys or their butt to get rid of potassium. All right. So let's say that they have good kidneys. They're able to make urine. I'll give them a loop diuretic. So generally that's the first thing I'll do is I'll give a loop diuretic, especially if they're hypervolemic, because that's going to help to get rid of volume and get rid of potassium. If they don't have good kidneys and they aren't really kind of like, and let's say that they're really hypovolemic, then I would maybe say, okay, I probably shouldn't give them a loop diuretic unless you're going to give them a loop diuretic. And on top of that, give them back fluids. So that's sometimes the only time where you'll do that. If you do that in the hospital, people will like look at you like you got like eyes all over your head. If you give a loop diuretic and then give them fluid, it doesn't make sense. But the whole point of giving a loop diuretic with fluid is the loop diuretic will get rid of potassium. The fluid is replacing the volume that you're taking out of their body. Okay. So that's the only time that you would do both, is if the patient's kind of like a little bit or hypovolemic. If a patient doesn't have good kidneys, don't even waste your time giving them loop diuretic, because you might not be able to pee out that potassium. That's when I would go with a potassium binding resin, and I would give them something like a Pataromer or sometimes sodium polystyrene sulfonate. Any of these drugs, you got to be careful though. The reason why is that particularly the SPS or sodium polystyrene sulfonate, it has the risk of intestinal necrosis. And so you don't want to give something that can cause, a dead gut.
It does not sound good.
No. So you got to be careful with that, but that is an option. If you need to get the patient's potassium out of the body and you can't use the kidneys, you can use the stool. They're going to dump the potassium into the stool. Whereas loop diuretics are going to dump the potassium into the urine. That's the way I would go with this patient. So I would go calcium, insulin, albuterol. I'd probably start with a loop diuretic, see how they respond, plus or minus fluid if they get a little bit soft with their volumes. If they didn't have good kidneys and I couldn't, like their GFR was really low, I probably won't give them a loop diuretic. I would give them something like a potassium binding resin. Lastly is if all that fails and I've tried everything I can, that's when I would call the nephrology team and say, hey, I need some help. I got a patient I've done everything for the potassium. It's still elevated. They're undergoing lots of ECG changes. They need hemodialysis immediately. So that's kind of the route that I would take for this patient population here.
Okay. Not too bad, right?
I don't think so. I think like if you're a learner out there and you're listening to it, I think at the end of this, you'll hopefully be able to say, I kind of have a decent diagnostic or systematic approach as to how to handle a patient with hypo and hyperkalemia, right?
It's always good review.
Exactly.
Well, that would conclude our episode then on potassium disorders.
Yeah, I think it would, man. So I really hope that you guys like this. I really hope that it was enjoyable, it made sense, and it taught you a lot. So please, if you guys like these, continue to keep listening to it. Also, if you want, we have a lot of awesome resources on our website. Go check that out if you guys want to. But the insurance, we love you. We thank you. And as always, until next time.